So next topic is Clostridium Difficile V6. An 83-year-old lady admitted with UTI develops diarrhea on the ward. How will you manage her? So as she is likely to have been given antibiotics for UTI, she probably has developed C. difficile diarrhea. So she needs to be isolated within the 2 hours of the onset of the diarrhea. Gloves and apron should be used during each contact, and afterwards hands should be washed with the soap and water because alcohol gels don't destroy the spores. Take a history, examine her, review her observation and drug charts. Ask the nurses to collect a stool specimen and send it to microbiology. Must take shape of container more than 1/4 full. Bristol stool chart 5-7. So what is Clostridium difficile? So it's a gram-positive anaerobic spore-forming bacillus that causes antibiotic-associated diarrhea and colitis. One of the most common nosocomial infections, produces 2 toxins, toxin A that is enterotoxin and toxin B that is cytotoxic. How it is diagnosed? So clinically, watery diarrhea, abdominal cramping, pyrexia, dehydration, fulminant life-threatening colitis, and suspect in any patient who have antibiotics in the last 2 months or 72 hours of hospitalization. So stool testing, 3 tests available. One is toxic gene by PCR and one other is EIA like ELISA immune sorbent assay, GDH, and toxin enzymes assay EIA. So not suitable as standalone. So start with PCR or GDH. If negative, no further test is needed. If positive, do EIA. If both are positive, C. difficile is likely reported. It's mandatory. Endoscopically, so we talk about history, stool, and then endoscopic pseudomembrane, which is yellow plaques ranging from 2 to 10 millimeters in diameter scattered over the colorectal mucosa. For if it's covering 14 to 25% mild disease, 87% fulminant disease. So what's the cause of C. difficile colitis? So what's the pathogenesis? So normally C. difficile, the patient who suffer with this condition, they are healthy adults and they harbor 2 to 3% C. difficile, the normal flora in their colon, and antibiotics are given which suppress the colonic flora and resulting proliferation of C. difficile and release of toxins, toxin TCD-A and toxin B. Toxins are absorbed by endocytosis into the colonic epithelial cells, causing cell death, and which can be visible as ulceration in the mucosa and increasing the intestinal permeability. The toxin directly promotes the release of pro-inflammatory mediators like substance P, TNF, IL-6, IL-8, IL-1, causing intestinal fluid secretion leading to diarrhea, and translocation of bacteria across the leaky intestinal membrane provokes a systemic immune response. The most common antibiotics are cephalosporin, amoxicillin, ampicillin, and also called macrolides, erythromycin, and clarithromycin, and other penicillin. C. difficile diarrhea has a mortality rate of 25% in frail elderly patient. Independent predictor of mortality at the age 70 years or older. Severe leukocytosis, leukopenia, and cardiorespiratory failure. How would you treat this patient? So for moderate disease, oral metronidazole is preferred route. C. difficile remains in the colonic lumen without invading the colonic mucosa. For severe disease, like any patient who has white cells of 15, who has 50% increase in the creatinine, temperature, abdominal radiological signs of colitis, use vancomycin. Faster symptom resolution, inhibit cell wall synthesis. Vancomycin is poorly absorbed and therefore there are high concentration within the intestine and few adverse system effects. But it's oral. IV vancomycin is not effective. And for nil by mouth patients, use IV metronidazole excreted into the bile. Exudation from the inflamed colon results in bactericidal level in the feces. So what are the treatment options for recurrent or refractory C. difficile? So there are 3 options. So recurrence occurs in 20% of the patient with treated with vancomycin and metronidazole. For first recurrence, repeated the course of vancomycin and metronidazole can be given. If further recurrence occurs, give fidexomycin. Fidexomycin if it's second recurrence. And fecal transplantation has also been shown to be effective in recurrent cases. 81% resolution compared to 20% for antibiotics trial. Current UK guidelines are fecal transplantation for recurrent cases. What do you know about Department of Health targets for C. difficile infection? All confirmed cases of C. difficile should be reported nationally. Each identified case should be assessed locally to see if the lapse in the care has occurred. Cases should be reported as a serious incident requiring investigation only if there was a lapse in the care that leads to the death or serious harm. Each hospital trust or CCG in the UK have individual targets for maximum number of confirmed cases per year attributable to a lapse in the care. The target is to reduce the number of cases by 1 from the previous year. Each case in the access of an organization target is subject to the financial section of £10,000 in 2018-2019. Thank you.